All right, welcome back to another episode of Three Plastic Surgeons and a Microphone. I'm here with Sam Jejurikar at Sam Jejurikar out of Dallas, Texas, and Dr. Sal Pacella at San Diego Plastic Surgeon out of La Jolla, California. And today we are going to be talking about rhinoplasty. This is the champagne of plastic surgery procedures. This is the one that, really defines what kind of plastic surgeon you are. And with that,
Wow.
I'm looking.
Okay. What about those plastic surgeons who don't do rhinoplasty?
Well, honestly, you're losers. No, I'm not. No, I actually, you know what? I actually have pretty much given up doing rhinoplasties at this point. I focused a lot on the other procedures, so I will put myself into that category. But if you're going to do rhinoplasties, you better do a really, 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 really good job with them. And that's why we have Dr. Sal Pacella, who's going to be talking to us today about rhinoplasties and showing us a couple cases and maybe some insider tips on, how to get a really good rhinoplasty result. So with that, I leave it to Dr. Jejurikar to give us our disclaimer today.
Well, before I get into the disclaimer, I feel like only a minute and a half into this, I've learned that Dr. Rhee has a lot of self-loathing. He considers himself to be a loser plastic surgeon. We don't do you that way, Dr. Rhee. I still respect you quite a bit.
Oh, thanks. I appreciate it.
Though I do perform rhinoplasty.
Very nice.
So this show is not a substitute for professional medical advice, diagnosis, or treatment. This show is for informational purposes only. Treatment and results may vary based upon the circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified health provider with any questions you may have regarding medical care, and never disregard professional medical advice or delay seeking advice because of something you may see in this show. With that, I'll turn it over to Dr. Pacella to lead this discussion on rhinoplasty.
I just love you guys. This is why I have so much good feelings every time I come with you guys. You guys just give me the love. No judgment.
You're the one that called yourself a loser. I love you more than you love yourself. I think you're a fantastic plastic surgeon. Yeah.
Thank
Anyways.
you.
So the world has changed. So, gents, talking about rhinoplasty. So, I agree with you, Sam, from Jersey. I consider rhinoplasty to be one of the holy grails of plastic surgery, if not facial plastic surgery. And I gotta say, I think, most of the surgeons I speak to or communicate with, they feel very similar. They have not, they do not want to continue to do rhinoplasty, find it very challenging, very difficult to get good results. And to be quite honest with you, I found the opposite. I find that doing a rhinoplasty is very calming, believe it or not. I mean, we're really dealing with two aspects of tissue, skin and the structural component of the cartilage and bone. And I could sit there for hours in doing this procedure and tweaking little millimeters. And I've just found it very therapeutic. How do you feel about it, Sam? Do you find it challenging on the table when you're operating?
So I love doing rhinoplasty just like you, but the reason I think why many plastic surgeons have or many decide they don't want to do it, it's a very different skill set than some of the other procedures that we do. It's an operation of millimeters, where literally you are moving at a very slow pace, just fine tuning things. So I think for those that are very detail oriented, it's very satisfying. For those who want to be done quickly, it's not necessarily as satisfying. I think the other issue is, and it's really interesting, when I look at what you're really well known for, it's for eyelid surgery, it's for rhinoplasty, it's for operations that are operations of millimeters, and it takes about a year for the swelling to go away post-op. And so sometimes it's challenging dealing with patients during that perioperative period, which I think is another reason why sometimes people just think, I'd rather do the body stuff, because when a patient has some post-operative swelling in their nose and it's going on for a few months afterwards, it can be frustrating for them, and in turn they try to make it frustrating for the surgeon.
I mean, for me, the reason why I stopped doing rhinoplasty about a year and a half ago was just because, and I'm a craniofacially trained guy. I mean, I know my way around a nose. Some of those cases are very long that I trained with, and that I know what Sal's talking about. I love the precision and the care that is taken with a rhinoplasty. But when the other aspects of my practice were taking off aesthetically, I was maybe doing 5 maybe 6 rhinoplasties a year, which I just never felt was enough for me to really feel up to speed, to feel really comfortable. And at that point, I felt like I wanted, again, you're right, it is a very precise operation. I felt that if I was only going to do 5 a year, that really wasn't going to be enough for me to get the best that I wanted for my patients. And honestly, from a financial standpoint, when I'm doing all this other stuff, it made sense for me to focus on the stuff that I'm doing every day, several times a day, all the time. And trust me, it wasn't an easy decision. I still love myself and I still think I am a good plastic surgeon. But there's no doubt that if you're going to do rhinoplasty, you have to do a lot of them, and you have to be able to feel very comfortable the minute you step into, the minute you step out. And if you're not doing a ton of them, you're not going to be as sharp as you could be with those. That's what I'm saying.
Right. One thing I would say is, by nature of my practice being very unique, because I do quite a bit of reconstructive surgery, my skin cancer practice is very highly, mid-face oriented. So I tend to do a tremendous amount of nasal reconstructions for skin cancer that are multi-stage operations, 3, 4, 5 operations, that are planned. And so, when you do these kind of disaster cases where honestly, somebody's had their nose completely removed, I find that doing a nice cosmetic rhinoplasty is very relaxing to me, believe it or not. The other thing I'd say is, I tend to see a lot of patients who have not only cosmetic issues, but also functional issues, because I do take insurance. I do functional rhinoplasty as well. I sort of look at this as kind of one package. So with that intro here, let me share my screen here. 1 second here. Let me just pull up my presentation. So Sam, when you were doing rhinoplasty routinely, how often would you do it, would you say?
I felt comfortable if I was doing maybe 15 a year. Like, I felt like that was a good number. I was doing more than that when I first started, because I was I was doing a lot of, like you said, functional rhinoplasty. In addition to that, I was taking insurances. But my last 2 years, I was doing like 6 or 5 a year. And I just said, this is just not enough for me to feel really solid with it all the time.
Okay. Do you guys see my screen here?
Yes, sir.
Okay. All right. So cases of rhinoplasty here. So, so to me, when I think about the concept of, or the conceptualizing rhinoplasty, it's really melding appearance versus function. And one of the things I tell patients that come in, many times they're referred from, say, an otolaryngologist or an ENT surgeon, head and neck surgeon, who came to see that particular surgeon for nasal obstruction. They may have a deviated septum or something called turbinate hypertrophy. And when the patient's going through that evaluation with the head and neck surgeon, they may say, well, I don't like this hump. And so then, the head and neck surgeon may not feel comfortable doing something. So I was referred the case. And so when I evaluate patients, I say to them, we have to blend, we have to work together appearance and function. For example, let's say you had a very small nose and breathing was a problem. And if we're just concentrating on function, if we just removed your nose, there'd be a hole in the center of your face that you're breathing through. And clearly that there's going to be no nasal obstruction, but that's going to look horrific, obviously, right? And on the same token, if you got the biggest nose, a Pinocchio nose, and we try to reduce that and reduce the size of the nostrils, you can clearly see how that's going to affect your function. So we really got to think about both of these. And I tell patients, you want one nasal surgery in your entire lifetime. So this is a good time to adjust both of these, because if you go back later on and you say, well, I don't like this hump after I had a septoplasty or turbinectomy, we could potentially be damaging things. So the slide advancement is a little slow here. Okay. All right. So here's a little short video here of a patient of mine. And this is a CT scan. So routinely when I'm doing a functional rhinoplasty, I oftentimes ask patients to undergo a CT scan. And so imagine we're looking straight on at the patient and we're taking vertical cuts through their face with the imaging. And so what we see here is we're looking at so we're sort of a little bit towards the back of the face. And in the middle portion here, we're seeing the septum, and we see these two fleshy pieces of tissue here called the turbinates. And the important thing about the turbinates is they oftentimes, when someone has nasal obstruction, allergies, or some other issue, these turbinates are huge. So you may ask, well, what is the function of the turbinate? Well, the turbinate is designed to warm air and increase the surface area as you breathe it in. And so all of these little eddies back and forth that are in the nose here. Sorry, the slide isn't advancing here. Hold on a second. Oh, there it is. Okay. All right. Okay, so now we're going through the nose here, and look at this top portion of the septum here. You can see here, this septum we're going to have a big deviation coming right here. If you see that right there, you see how that septum kind of grows into the side here. So that's what's called a nasal spur. So you can clearly see how that may affect the breathing component. This is the turbinate that I'm talking about right here. You see how thick and heavy that is? So it's clear how that can affect somebody's breathing. Any comments on that, gents?
Yeah, I think that's a really good illustration. Turbinate, those are giant turbinates, those fleshy balls in the airway, giant turbinates, and usually a reaction to things, oftentimes not necessarily the primary issue, but if you don't address it during surgery, patients still will have difficulty breathing.
Absolutely.
Right. And the other component of this too is, let's say this particular patient went to see somebody who's just going to plan on doing cosmetic rhinoplasty, and they don't go deeper into the septum and take that little septal spur out. That patient is going to be plagued by nasal airway obstruction the rest of their life if that's not taken care of. So we want to think about this as a package. So here's a little shameless plug for my textbook on Mohs reconstruction. These are some imaging. These are some images from that textbook, but I think they do a very good idea of kind of illustrating exactly where the structure of the nose is. So when we look at the top of the nose near the eyes, that component is bone. Okay. Now, somewhere around the middle portion of the nose, when we're going down inferiorly, there are really two sets of cartilages that we're looking at. There's the upper lateral cartilage and the lower lateral cartilage. And what I want to draw attention to here is this area right here on the side of the nose here. This is called the nasal ala. And what we're referring to here is the fibroareolar cartilage. If you were to take your finger and put that on the same side of your face here, I think there's a misconception in the world that cartilage exists on this portion of the nasal ala, but that's actually not true. There's no cartilage on the side of the nose, on the side of the nostril. What that is it's fibrous tissue and fatty tissue that create this kind of tube of flesh. And the issue is when that area here, if it's been untouched, it creates a nice arch to tissue. Okay. What I like to think about is this is a PVC pipe that's underneath the sink. That's a big round piece of tissue or big round pipe. But if you weaken that pipe, you take a bite out of that pipe, oftentimes there can be collapse of that structure. And that's the key component here, I think, when we're talking about balancing form and function. If we go in there and muck up that fibroareolar tissue during a cosmetic rhinoplasty without taking advantage or understanding how we're going to change the breathing component, that could be a devastating problem for rhinoplasty. Any comments, gents?
I think it's a really interesting conundrum that surgeons face, because that fibroareolar tissue that you're talking about doesn't have any cartilage in it, but yet I think what you're telling the viewers, at least that's what I got out of it, is sometimes when you're doing the reconstruction on it, because it could collapse, you do have to add some structure to it in the form of cartilage to try to provide that support. So it doesn't have that in its native structure, but sometimes you need to add it to it after you do a surgery in order to preserve function and even form.
Right. A lot of times when you're first examining a patient, you check for that external valve and you see how much support it natively has. And then in a lot of cases, and I'm sure you'll describe it in terms of adding that support to that rim to prevent it from buckling or bowing or collapsing.
Right. Exactly. And this is why I find it so enjoyable, is to sort of it's thinking about this in 3 dimensions and structure. So let's kind of jump into a few cases here. So this is a nice young lady in her 20s who very, very unhappy with the appearance of her nose and her facial profile. And and really had some issues related to breathing. She was snoring at night, a lot of allergies, a lot of runny noses. And so, we really want to address these issues. So maybe for the one other plastic surgeon that does rhinoplasty and on this podcast, Sam from Dallas, how would you approach this? Or what do you actually, first start, tell me what you see.
So sure, and I just see a lateral view. I assume there's no other views for me to look at.
Correct.
But on this lateral view, you basically see a woman that has what we call a dorsal hump, where basically there's a combination of both upper lateral cartilage and nasal bone hypertrophy that's giving her a not the most feminine appearance to her nose. When you also sort of assess how projected the nasal tip is, or how far the nasal tip is, if you were to imagine you had sort of shaved down that hump, I think you would actually see that her nasal tip is either close to normal or maybe just a little bit projected too far. And it's something that you would have to sort of make a decision intraoperatively about whether or not you were going to bring that tip back. Typically, when you do an extensive reduction of the dorsal hump, you can create what's called an open roof deformity. So when you shave that down, you can sometimes see the edges of the nasal bone. So this is someone I would talk to you about doing some relatively common and basic maneuvers we do in all rhinoplasty, which is removing bone and cartilage from the upper 2/3 of the nose, breaking the bones along the side called nasal bone osteotomies to reduce the overall size. And then I'm assuming when we see her tip, there'll be some modifications of her tip that are required as well.
I think the other thing to look at is her overall facial proportion. So I remember when we were residents, they forced us to do a facial analysis for every rhinoplasty patient we did. And I would look and see, where is her menton sitting? Where, what are her overall facial proportions, and take that into account in the rhinoplasty planning.
And that's
menton. That's a craniofacial word. What's a menton?
Well, only a few people could really talk about that. Maybe some of my mentors.
Yeah. Henry could. I think Steve could too.
Henry,
right. But that's actually a great point, like an amazing point that Dr. Rhee, who for some reason has given up rhinoplasty yet is still good at doing the analysis on it. It's probably the only operation that I do where I actually suggest another procedure to someone. And so what Sam is getting at in this patient is this patient has a very underprojected chin, and it's someone who, even when you reduce the nose, it's someone that you might talk to you about either doing, at least in my hands, a chin implant, but in Dr. Rhee's hands, probably a genioplasty or an operation where you actually might bring the bone forward. But amazing point that Dr. Rhee brings up. Maybe you should think about getting back into rhinoplasty again.
So excellent point, Jen. So you're sort of dead on with my analysis as well. Now, we did discuss performing a chin implant, but it's something she didn't want to do, obviously, for various reasons. And so and the whole other side of this was the functional component of her nose. So she had really substantial nasal airway obstruction. And so we want to address both of those. So here's her result afterwards. Okay. And I think what I found myself in this case doing is really dealing with an overprojected tip. So let's start from the top to the bottom here. So this area of the nose here is called the radix. And many times when someone has a big, heavy hump here, they have this sort of what we call the Apollonian profile, or Greek or Mediterranean profile. And that's when the radix of the nose is flush with the forehead. And so in order to create a little bit better slope, you oftentimes have to take the bony resection up in this region here. And sometimes I use a combination of chisels, sometimes a combination of drills to get down this bony radix. And so I also did an osteotomy where we took off the dorsal hump and brought the nasal tips together, or the nasal bones together, but also worked extensively on this tip here. The other thing I wanted to point out here too is oftentimes when you have a very overprojected nose and you set that nose back, what happens is the nostrils tend to flare, okay? And so that's something we have to pay attention to. So if we're not paying attention to that, somebody can have a really good profile of their nose, but then the nostrils will flare and it'll look like a big wide nose at the bottom. So I did something here called alar excisions, or weir excisions at the corner. And what that does is it reduces the overall dimension of the bottom of the nose. Now, going down at the upper lip here. So when I did take this nose back, and you can see I took it back probably a good half a centimeter. In order to make proportion here, this patient had quite a bit of bony excess in this area right here at the junction of the nasal bone here and the upper lip. And so what I did in this scenario here is I actually went ahead and drilled out a little bit of bone right here in order to create a much better lip profile. And magically what that's done is it's changed her entire nose. It's changed her entire facial profile. I did this all without a chin implant. Okay. So no additional tissue was added to the chin. And so this simple act of taking out some bone right here set her mouth down in such a way that it added additional support and additional volume to her chin. And that was a surprising appearance for me after the surgery. I didn't think this could be achieved with just simple excision up here and without a chin implant.
Did someone put filler in her chin? There's no way. There's no way.
I swear to God, I asked her that. Did you get anything done to your chin after our surgery? No, not one thing.
I would put money. I would have put money. You did something to the chin on that one.
I did not.
And with the amount of bony work you did, are you sure you're not a craniofacial surgeon? Because again, only a few of my mentors could really have gotten a result like this, I think. And it's pretty amazing. That's pretty amazing.
What do you think? Maybe Steve? Maybe Henry?
Maybe Henry.
Yeah. Maybe Henry. Yeah.
All right. So let's go on to another case here. So we have a nice young lady here. She was a softball player in college. And you can see here, she's got this kind of bony hump on her dorsum here. She's got kind of a wide tip. And so, gents, what do you think about that here?
Do you want to start with this one, Sam?
She definitely appears to have wide nasal bones. Not seeing the lateral, I would guess she has.
Skip through the results here.
Okay, there you go. All right, there you go. I would say, Sam, if you want to jump in, I'm happy to let you jump in.
She's got sort of a complicated lower lateral cartilage situation. She's got what we call, alar malposition, where her tip looks just relatively pinched. So this is one of these, when Dr. Pacella was talking earlier about how the fibrofatty portion or the outer portion of the ala doesn't have cartilage. She's someone that actually could probably use a little bit more cartilage there to make the tip look a little less pinched, but beyond that, the usual things that we had sort of talked about her dorsum. Tell us what you did, Dr. Pacella.
All right. So we did the same kind of approach, an open rhinoplasty. And one of the things I placed in her, also somebody, again, who's had functional concerns with her nose. So in order to achieve a nice rectangular appearance of the dorsum, I did a maneuver called spreader grafts. And what these are is when we take cartilage out of the nose at the nasal septum, we can add in some additional cartilage in order to recreate these dorsal aesthetic lines. And that has really helped her nasal tip quite a bit. And so you can see here, that tip has a nice kind of super tip break that we see. And she's got some nice tip defining points now at the tip of the nose. You made an excellent point here on that fibroareolar cartilage. So I did do a little bit of augmentation to this area in order to drop the ala down and add a little bit more structural support. So this is what's called an alar rim graft. And so very, very happy with the result here.
What percentage of patients would you say you do spreader grafts?
Probably a good 70%. Again, most of these patients are dual patients that have both cosmetic and functional concerns. So usually if there's a functional concern, I'll add a spreader graft, but I've been kind of backing off of it a little bit more at the sort of mid end of my career here.
I mean, when I was doing them, I was using that technique where you kind of take that upper lateral and you kind of turn it into, turn it into the septum and just sort of use those as spreader grafts.
Spreader flaps, yeah.
Yeah,
spreader flaps.
Yeah. And I thought that was super helpful and saved me time from screwing around with the spreader grafts.
Right. All right. So now let's get into the more craniofacial realm here. So maybe Sam Rhee will have a lot to say on this one. So here's a gent who was born with a unilateral cleft lip. And one thing we commonly see in patients with cleft lip deformities is they have a lot of destruction in the nose. He had a bony deficit to his cleft lip as well. So the maxillary bone had an area of bone that had a bad platform to things. Let's see here. Yeah, let's go. I just want to show you this picture here. Okay, so if you look at the worm's eye view of things here, you see how these kind of tips are separated right here. And this nostril area is almost half the size of the opposite side. But the important thing here is this kind of bony aspect of the nose here, the maxilla. This area here of the maxilla is called the puriform aperture. And that area is recessed substantially. So whatever you do to that tip of the nose, unless you're adding some additional platform here, it's just not, it's, as our mentor Kevin Chung used to say, it's not going to.
This is very classic cleft nasal deformity that you would always see in patients, because when two things, the nostril is tight, because when you do your cleft lip repair, you're cheating and pulling the tissue together to do the repair, but that generally leaves the nostril tight unless you do some maneuvers like preoperative, cleft treatment to expand that area. And then the second thing is there's by definition a maxillary bony defect, or the upper jaw has an absence where the cleft lip is. And generally speaking, you'll go in around 9, 12 years of age and you will bone graft that area to correct that. But a lot of kids never get that, and so they're left with a permanent bone deficit there, which you can see is basically the collapse. There's a lack of foundation, and the nose collapses into that area. So you are basically doing cleft work here, Sal, which my mentors would tip their hats off to you, because this is what's, you recognized it and you identified it, and you're taking care of it.
Right. So that's exactly what I did. So he actually did have what's called an alveolar bone graft in the past, but it was not really, it's resorbed a bit over the years and so one thing I did was I got a 3D craniofacial CT. And so I ended up adding a bit of iliac crest bone graft to this area here in order to build up the base of the nose. And so you can see here, this is his worm's eye view. And what I did was we added a substantial amount of projection here. I utilized some cadaver cartilage to really help build up the tip substantially and add some structure to the tip of his nose. You can see here, if you look, that nose is essentially curled down. And the reason for that is really that scarring and that pull and that loss of tissue support at the maxilla. And so adding that cartilage graft, the cadaver cartilage graft, as well as his own bony graft, it really helped with his lip. It helped with his nasal projection, and just overall has a better appearance to his nose. And the beautiful thing about a case like this is, look at his lip here. Okay, so I did very little to the lip. I maybe added a little bit of fat to the lip here to add into that scar. But when your nose looks great, it takes away from your lip. It kind of goes into that classic teaching that this is the area of the face that people focus on, this central triangle, the eyes and the nose. And so making this nose as perfect as it can be really takes the onus away from that lip.
This such a challenging case. Did you one of the things that I don't think the viewers will necessarily recognize is how hard it is to close the soft tissue after a case like this. Patient who's had contracted tight skin envelope for years. You added a bone graft, which really helped that depressed scar, and then you put in a large strut or columellar strut using cadaver cartilage graft. It's hard to close that incision because it's tight and contracted for years. That's a fantastic result.
I don't think I've seen a better adult cleft secondary nasal repair than this. It's kudos to you. That is amazing. How did you do this in one stage, or was this multiple stages for you?
One stage.
Wow. Blown away. Absolutely blown away on this one.
Took a bit. Took about, my average rhinoplasty time is probably about 3 hours. This probably took about 5 hours with the bone graft component, the other nasal cadaver graft, things like that. So one final quick case here. I know we're running out of time. Another patient with a wide nasal tip, wide base of the ala. So we did all these kind of maneuvers like we talked about. I did a bony resection. We did osteotomies and did a substantial amount of tip work here. Also did those weir excisions at the nasal ala to prevent nasal alar flaring. And, cosmetically, just this patient's very happy with the result, good super tip break. So, these cases of rhinoplasty, I just find these exceptionally satisfying. In the operating room, like I said, I'm a surgeon who really, I get my rush out of dealing with things that are millimeters each. And so that's, I think, where I'm in my comfort zone. things. So that's about it for the cases, gents.
Great cases. I think they really did a nice job of illustrating to all of our viewers just the various components of the nose that we're looking at during these cases. I mean, you talked about grafts to improve breathing and change the way the dorsum looked. You talked about grafts to improve the tip and the ala. There's a complex relationship between all of these areas, and it's nice for the viewers just to see how someone like you approaches it.
Yeah, it justifies my reason for not doing them anymore, and I'll just send them all out to La Jolla. I mean, why not? Like,
Or Dallas. Or Dallas. I do one of these too.
Amazing results. And it's like you said, those refinements, everyone can see it, but we know technically achieving that it takes a tremendous amount of skill and experience.